Today we will be talking about Parkinson's disease. What is Parkinson's disease? What are the symptoms and signs in Parkinson's disease? What tests we do to diagnose Parkinson's disease? And what are different medical and surgical treatment options available for the treatment of this disease? So before talking about Parkinson's disease proper, let me tell you about one terminology called Parkinsonism. Parkinsonism. What is Parkinsonism? It is a constellation of symptoms like rigidity, tremor, hypokinesia or bradykinesia, postural instability. If these symptoms are present, then we call that patient has Parkinsonism. So what are the causes of Parkinsonism? So let me write it here. What are the causes of Parkinsonism? So number one is idiopathic Parkinson's disease. Idiopathic Parkinson's disease accounts for 80% of the cases of Parkinsonism. As the person ages, there is degeneration of the nerve fibers, striatonigral neurons, that leads to idiopathic Parkinson's disease. Second is genetic cause. Genetic cause like if associated with LRK2 gene, Parkin gene, then more susceptible for Parkinson's disease. And patients with first degree relative with Parkinson's disease have 2 to 3 times more likelihood of having Parkinson's disease. And another genetic causes like spinocerebellar ataxia, Huntington's chorea. Okay. And the third cause is environmental toxin and drugs. Environmental toxins and drugs. So what are different drugs that can cause Parkinsonism? Antipsychotic drugs like risperidone, clozapine, olanzapine. Okay, antipsychotic drugs. Metoclopramide, which is an antiemetic drug. These are dopamine blockers. Metoclopramide. And other causes like progressive supranuclear palsy, multiple system atrophy, dementia with Lewy bodies. Okay, so these also are the causes of Parkinsonian symptoms. So you know what is Parkinsonism? What are different causes of Parkinsonism? Now let's talk about idiopathic Parkinson's disease. Idiopathic Parkinson's disease. Here there is neurodegeneration of striatonigral neurons, that leads to low dopamine, and the clinical features that an individual experiences is because of the low dopamine in the basal ganglia pathway. And here you can also see Lewy bodies. Lewy bodies, these are synucleinopathies. These are called synucleins. These are deposited in cortex, brainstem, basal ganglia. Okay. So what are the clinical features that patient have? So it is divided into non-motor symptoms and motor symptoms. Non-motor symptoms and motor symptoms. What are non-motor symptoms? One is hyposmia. Second is apathy, depression, anxiety, hallucinations. So these non-motor symptoms can precede motor symptoms by few years. Okay, and motor symptoms, what are motor symptoms? Like a stiffness of the body, that is called rigidity, a stiffness of limbs, then tremor of hands, it is resting tremor, then hypokinesia, which means slowness of movement. You can see the slowness in writing. They write a small letters, that is called micrographia, and they also speak with low tone of voice, monotonous voice. So hypokinesia manifested in all his activities of daily living, like gait is called fascinating gait. they have difficulty initiating the step, and once they start the gait, they have difficulty stopping, and sometimes freezing occurs, and they have also difficulty turning back. So let's suppose patient walks from here and goes here, and they have to turn back, so they have difficulty turning there. They stumbles there, and due to postural instability, fall can occur. So those are the motor symptoms. And apart from the non-motor symptoms that I told you, like hyposmia, apathy, depression, anxiety, other non-motor symptoms can also occur, like in other synucleinopathies, like sleep disorder, hypersomnolence, and rapid eye movement, sleep behavior disorder. Okay, so sleep disorders can occur, and sexual dysfunction can occur, erectile dysfunction can occur. So these are also the things that we need to ask to patient in his history. Okay, because we also have to address those symptoms as well. And other complaints like fatigue, sphincter disturbance, weight loss, these can also be there. Okay. So we talked about clinical features of Parkinson's disease. And now let's talk about on examination. You will find rigidity, and rigidity is of lead pipe rigidity, cogwheel rigidity, ratcheting movement can be there. Okay, and you can test postural instability with pull test. You can pull the back of the patient backward and see whether he can balance himself or not. If he cannot balance himself and starts falling, it means the pull test is positive. And you can test the tremor with by placing a paper on his hand, and whether you can see if there is a minimum tremor, then you can notice with this movement of the paper. Okay. And if patient has autonomic dysfunction, then you obviously will test for orthostatic hypotension. And another point that I would like to tell you, that if you see these features like prominent autonomic dysfunction, like postural hypotension, sphincter disturbance, or gaze palsy, or dementia or cognitive impairment within 1 year of onset of symptoms, or if this is symmetrical symptoms, or there is no response to levodopa, in this condition you have to think of Parkinson plus syndrome. So what is Parkinson plus syndrome? I have talked this in another lecture. It comprises of multiple system atrophy, progressive supranuclear palsy, dementia with Lewy bodies, corticobasal degeneration. So we talked about idiopathic Parkinson's disease and what are its differential diagnosis. I told you multiple system atrophy, corticobasal degeneration, progressive supranuclear palsy, and dementia with Lewy bodies. You have to differentiate these conditions from idiopathic Parkinson's disease. Now let's talk about investigations. How do you diagnose it? So you don't have to do MRI or dopamine transporter scan with SPECT. You can basically do clinical diagnosis. But if you have to exclude cerebrovascular accident or other Parkinson plus syndrome, then only you go for imaging modality. So otherwise it is clinical diagnosis. Now what is treatment? So treatment, one is medical management, another is supportive management, another is deep brain stimulation. So before talking about the treatments of Parkinson's disease, what I would like to again reiterate that Parkinson's disease is a progressive neurodegenerative disease. We don't have any treatment that can cure Parkinson's disease, or any treatment, we don't have any treatment that can halt the progression of the neurodegeneration. So basically what we do, we do is that we only do symptomatic management. Whatever patients has symptoms like stiffness, tremor, or hypokinesia of the movement, so we can address only those symptoms, but the disease will continue its natural course, whatever, whether we treat or not treat it. Okay, but since the symptoms are very disabling and it can affect the daily life, so we treat with drugs, and if it is not responsive to drugs, then we have to go for deep brain stimulation. But nowadays they tell that even deep brain stimulation can be done in earlier stage, you don't have to wait until late stage. But the thing is that if motor symptoms are not responsive to dopamine, I mean levodopa, then there is no advantage of doing deep brain stimulation. They tell that at least there should be 30% improvement in motor symptoms in UPDRS score to qualify for referring patient for deep brain stimulation. Then you may be thinking that oh, he is already responding to levodopa, then why I have to send for deep brain stimulation? So in those conditions, sometimes what happens that motor fluctuations occur. What is motor fluctuations? You might be wondering. So let me put this in perspective of one case scenario so that it will have easy understanding. Let's suppose one patient is taking levodopa at 8 am, another at 12 noon, and another at 4 p.m. So patient took 125 one tablet at 8 am. Patient was symptom free at this moment, and at 11 am patient again started having symptoms, the hypokinesia, rigidity, tremor, and patient again took medicine at 12 noon, and patient was symptom free here, and at 3 p.m. patient again started having symptoms. This is called wearing off phenomenon. Wearing off phenomenon. It means that the effect of medicine starts to wear off as the time passes. So in this condition, what you can do, you can again give levodopa at this point, or inhaled dopamine agonists are available. So we can give inhaled formulations at this point when patient experiences wearing off symptoms. And another condition is called sudden off symptoms. Sudden off symptoms. What does it mean? That patients suddenly have symptoms regardless of the timing, dosing of the medication. Patient suddenly experiences symptoms. That is called sudden off symptoms. So these are two motor fluctuations. And another is levodopa dyskinesia. Levodopa dyskinesia. Dyskinesia. What does it mean? That patient experiences dyskinesia with the increasing dose of levodopa. We initially will start with 100 by 25 combination of levodopa carbidopa tablet, half tab TDS, and then we go up titrating it to 3 tab TDS. So when we are increasing the dose, dyskinesia can occur due to levodopa effect. Okay. So in those conditions, motor fluctuations, levodopa induced dyskinesia, we have to refer patients for deep brain stimulation. So that is the indication of deep brain stimulation. And before sending patient for deep brain stimulation, you have to know that patient should not have underlying mood disorder, depression. Those things should not be there before qualifying patient for deep brain stimulation. Now let's talk about medical management. So I already told you that levodopa carbidopa combination. One is levodopa. Second is COMT inhibitors like entacapone, tolcapone, entacapone, tolcapone. Third is dopamine agonist. Dopamine agonist like ropinirole, pramipexole, ropinirole, pramipexole, transdermal roticotin, and fourth is MAO-B inhibitors. MAO-B inhibitors like selezelin, raselezilin, safinamide, and fifth is amantadine. It is anticholinergic. Amantadine. These are different drugs available for treatment of Parkinson's disease. So when to choose dopamine agonists over levodopa? Dopamine agonist over levodopa. If age of patient is less than 65, why? Why do we choose dopamine agonist when patient is younger age? because you know some experts say that if you initiate levodopa early in the course of the disease at younger age, what happens that there is a high chance of patient developing motor fluctuations, levodopa-induced dyskinesia as the natural courses of the disease progresses. So they reserve levodopa for the later part of the disease, like when patient is more than 65 years of age. Okay. And if patient experiences levodopa-induced dyskinesia, then also we go for dopamine agonists. And if patient symptoms are not responding to levodopa dopamine agonist, then we also have to add COMT inhibitors, MAO-B inhibitors, amantadine. Okay, so these are the medicines available for symptomatic control of Parkinson's disease. And another is supportive management. Supportive management means you have to assess for fall, assess for depression, and teach about physiotherapy of limbs, speech physiotherapy, if speech is involved. Okay, so supportive management is also equally important. And the last is deep brain stimulation, that I already told you. So basically, let me make you understand, this is the head of an individual and this is the chest. So what they do, that they put the battery at the subclavian region and they place a wire and they implant the electrode inside the globus pallidus internal thalamus. And just like pacemaker, there is constant discharge of this electrode, and there is 24 hours 7 days it is on. Okay, so it is on continuously, just like pacemaker, and this is discharging constantly via electrode inside the globus pallidus internal thalamus. And other options like palidotomy, thalamotomy are available, but these are not done nowadays. So basically what we learned today is that what is Parkinson's disease, which is a neurodegenerative disease. We cannot halt the progression of the disease. We don't have any medications. We only do symptomatic treatment. Then we learned what are the clinical features. We learned about non-motor symptoms, motor symptoms, and third we learned how to diagnose. So we don't have to do MRI or SPCT, dopamine scan, DTAP, that is called DTAP scan, dopamine transporter scan. We don't have to do unless we suspect cerebrovascular accident or other mimickers of Parkinson's disease. And then what we learned with treatment modalities, medical management, supportive management, and deep brain stimulation. So this is all about Parkinson's disease in brief, in a nutshell. Thank you.